now we've got a new treatment option post the COMPASS trial for patients with peripheral artery disease, for that matter, even patients with stable coronary artery disease that are high ischemic risk. And the approval of COMPASS, or I should say the FDA approval of COMPASS results and labeling of Rivaroxaban have really opened up the field in terms of patients that are eligible for this therapy. The label's actually rather broad. The trial included a broad array of patients with stable CAD and PAD. That, I think, is good for patients because there are a lot of options. I think it's also challenging for physicians because there are a lot of patients who are potentially eligible for this form of therapy. And I think it probably makes sense to focus efforts on patients who are at highest ischemic risk, especially as physicians are becoming comfortable with using a low dose of a NOAC in patients with stable atherosclerosis. Of course, we're using NOACs at a higher dose in atrial fibrillation and DVT, so there's a lot of experience out there. But here we're talking about a lower dose, Rivaroxaban 2.5 twice a day, plus low dose aspirin, which in the US would be 81 milligrams a day. And there is a bleeding risk we saw in COMPASS, a significant excess in major bleeding. Fortunately, we didn't see any significant excess in fatal or intracranial bleeding, but still do need to be cautious and not use this therapy in patients who are high risk of bleeding. Be cautious in patients who are older and who have other risk factors for bleeding. But in patients who have a low risk of bleeding, haven't had bleeding problems on aspirin, but remain at high ischemic risk, there I think the addition of Rivaroxaban 2.5 twice a day could be really useful to reduce future events.